Good morning and welcome. On behalf of ODM, I'd like to welcome everyone to our stakeholder series for the Next Generation Pharmacy program. My name is Sean Eckert. I'm the Pharmacy Director for the Ohio Department of Medicaid. And I am joined today by Dave Hartzell, Clinical Account Manager with Gainwell Technologies, and AJ Summers, a Senior Manager with Myers and Stauffer. We're going to talk about specialty pharmacy today. And ODM recognizes that while specialty pharmacy constitutes just a subset of the total pharmacy claims, these claims are typically very high cost claims and very important to ensuring access due to the indications for these products for rare and serious diseases. So we really want to ensure that we engage directly with providers in this space. As a reminder, everything that we do here at ODM it really is driven by our next generation mission statement, which is to do better for the people that we serve. So we want to focus on the individual. We want to be a national leader in healthcare innovation. We want to be a good partner for providers, provide a fair and transparent reimbursement structure, and ultimately improve health outcomes, leading to a healthier Ohio. Next slide, please. This is a reference slide, just for future reference, some acronyms that we've got throughout the presentation. The most common acronyms that we'll be using today, the first one is PPAC, which is the Pharmacy Pricing and Audit Consultant. And that is the vendor that we've selected for that scope of work, which is currently being held by Myers and Stauffer. And the SPBM is another acronym, which is a Single Pharmacy Benefit Manager, which is currently being served by Gainwell Technologies. Some pricing acronyms that we'll be discussing today. OAAC, which is short for Ohio Average Acquisition Costs. That is one of the pricing metrics that we'll be using in the Next Generation program. NADAC, which is the National Average Drug Acquisition Cost. And lastly, WAC, or Wholesale Acquisition Cost. The rest of these will be used in the presentation. We put this here just for future reference, though, so that you can refer back to these in the event that it's unclear what the abbreviation means. Next slide. So during our March presentation, we spoke about some general structure around specialty pharmacy, particularly some details about network criteria, and this was in general. The focus today really is going to be on specialty pharmacy. Regarding the dispensing fee structure, we want to provide an overview of the general structure. We cannot, unfortunately, give specific figures today. That will be at the next webinar that's planned for the month of May. Also, we'd like to talk a little bit about medical versus pharmacy benefits, which is particularly important for specialty providers to understand, as this is a very common issue in specialty pharmacy with respect to which benefit medication may be covered under. We also want to speak a little bit about 340B covered entities and some of the considerations that those specialty providers may have. Then we'll look to Gainwell to provide an overview of the prior authorization and prescribing considerations under the SPBM program. And then lastly, we'll move to Myers and Stauffer for a review of the OAAC survey process. And that information will serve as a reminder for the survey process that we discussed during the March meeting. Next slide. So first, we'd like to talk a little bit about network criteria and credentialing of specialty providers. So SPBM will currently be accepting the 3 accreditation organizations that you see here. So URAC, the Joint Commission, and ACHC accreditation. These are the most common accrediting organizations within the specialty pharmacy space. And this accreditation assists ODM and the SPVM in ensuring high standards of practice within specialty pharmacy. Regarding medical claims, the managed care organizations will retain the responsibility for the payment of provider-administered drugs. These are covered under the medical benefit. We'll speak a little bit about that in more detail later, but that is an important consideration that all provider-administered drugs generally are covered under the medical benefit, with some limited exceptions. Additionally, pharmacies must provide a direct contact for escalation, and this is provided to Gainwell. It's important to note that Gainwell did begin outreach for contracting in late March, and all enrolled pharmacy providers should have received communication from Gainwell. As a reminder, if you have not received that communication from Gainwell, we ask that you please reach out to ODM via email, and that email address will be provided at the end of the slides today. The next item is that the specialty pharmacy must provide for a nurse or pharmacist available to the members by phone 24/7, 365. That is important for members that may have questions about their medication and ensuring appropriate access to those clinical resources when needed. The next component is pricing survey participation, and this is the OAAC pricing survey. Participation in that survey is mandatory for all providers, and this is especially important to ensure that we have quality data for pricing of specialty drugs, and we encourage all providers to participate in that survey. In addition to it being required, really to ensure that we have documented your experience as a specialty provider within that survey. This is also important because there's typically not NADAC pricing for these agents, and so we want to ensure that we have good coverage of specialty drugs within the OAAC survey process. One exception is for 340B pharmacies that are 100% 340B. And AJ will speak more about that later during the OAAC part of the presentation. Some other considerations for pharmacy providers is that we do require an expedited delivery option in the following clinically appropriate situations, which would be things such as dosage changes that cannot be addressed with the patient's current medication supplies, adverse effects that require treatment changes, as well as clinical decompensation requiring immediate treatment as determined by Gainwell or by ODM. And then lastly, specialty providers must adhere to the ODM specialty policy and the Gainwell utilization management strategies, and those can be found in more detail in the provider manual. Next slide. So the specialty drug list will be developed jointly, both by the PPAC vendor and by ODM. This specialty drug list will be updated on a weekly basis. And how we determine whether or not a drug is a specialty drug really is by looking at a number of different variables. And those variables could be things like the distribution strategy of the drug and whether it is a limited distribution agent or has no limitations on distribution. We also look if there are extensive clinical considerations that are associated with dispensing the medication. These may be things like counseling requirements, where we anticipate a higher level of counseling services would need to be provided, and where we want to ensure that we have qualified specialty pharmacy providers that are providing those services, as well as that we reimburse appropriately for those level of effort considerations. We also look to REMS program requirements in determining whether a medication is specialty. We look at the cost of the medication as well. We look at access considerations for members, and these are drugs that are particularly important for public health. So these could be things like medications for hepatitis C or substance use disorder, where we want to ensure that our members have appropriate access to those medications. And so that definitely plays into whether or not a medication would be defined as specialty. And then lastly, the method of administration. So both the route and manner of administration, as well as the setting that the drug is typically administered in. Next slide, please. So some examples of specialty medications. These we've picked the top 20 or so medications that we are currently planning to define as specialty medications. These are some of the more common medications. This slide is just provided as a reference to give an idea of the types of medications that we will define as specialty medications. Next slide. And then some examples of public health drugs that we are not planning to consider specialty drugs. These are things like antiretrovirals for HIV. These also could be hepatitis C agents, as well as medications for the treatment of opioid addiction or substance use disorder, where we want to ensure that we have appropriate access for all of the members and that they can easily obtain these medications when medically necessary. And that's really the critical theme here with these particular agents. Next slide. Regarding ingredient cost reimbursement methodology, we have about 3 different categories of reimbursement structure, and those are non-specialty, specialty, and clotting factors. 340B is kind of its own separate thing, which we'll kind of talk about here in a minute. But in general, that non-specialty, specialty, and clotting factor distinction is the most important. One thing to note here, with non-specialty and specialty medications, we will be using the lesser of OAAC, NADAC, WAC, or the submitted or usual and customary charges for both non-specialty and specialty. One thing to note between those 2 items is that the specialty medications will carry a specialty dispensing fee that is different from the standard dispensing fees that you would find for non-specialty medications. And again, we've discussed some of the reasons for that increased dispensing fee, really around those level of effort considerations, as well as increased overhead costs that we know that specialty pharmacies incur from our cost of dispensing survey. Regarding clotting factor, that will be reimbursed at the lesser of the OAAC or the submitted and usual and customary charges. And it's important to note with clotting factor that there is a special clotting factor dispensing fee. Again, owing to information from the cost of dispensing survey that we perform every 2 years in Ohio, where we do understand that pharmacies that are dispensing clotting factor do incur significantly higher overhead costs than traditional pharmacies. And so we want to make sure that we appropriately reimburse for the provision of those products to our members. And then lastly, for the 340B covered entities, we will be reimbursing per ORC 5167.123, which specifies that we will be paying at NADAC plus the standard dispensing fee, or if there is no NADAC, we'll pay at WAC plus the dispensing fee. And that pricing is set per that ORC section. And then it's important to note with the dispensing fee that we do not discriminate on the basis of 340B status. And so for those 340B covered entities, they are paid the standard dispensing fees that all other providers are paid. We do not reduce that dispensing fee in any way, shape, or form, just solely based on 340B covered entity status. Next slide. Regarding dispensing fee structure, dispensing fees for all medications under the pharmacy benefit will be determined both at the provider and the medication level. Specialty pharmacies, we do know from our cost of dispensing survey, they do typically incur higher costs. And these are for various reasons, such as accreditation requirements, shipping and handling requirements of the medications, and extensive packaging and cold chain integrity issues, staff training, as well as more extensive patient counseling and regulatory requirements. We do understand that at ODM, and so we want to ensure that we're reimbursing appropriately. Regarding standard dispensing fees, which we're terming the base dispensing fee, this is based upon the provider. There will be 3 tiers within that dispensing fee in the overall program. Those tiers are determined by a number of different variables that ODM is defining, and we'll work with the PPAC vendor as well on those. And more information about those will be discussed in our next stakeholder webinar, where we will discuss that reimbursement structure in detail. It is important to note that for specialty pharmacy providers, as defined by ODM, they will be placed in tier C, which is actually the highest tier, again, to reimburse for that increased overhead in operating a specialty pharmacy line of business. Some other differences really within the specialty pharmacy structure that we do acknowledge is the cost of any sort of special equipment for mixing and the storage of these types of medications as well. Regarding specialty medication dispensing fees, for qualified providers that are dispensing specialty medications, we will be paying an additional specialty dispensing fee component, and that is added to the base dispensing fee to arrive at the total dispensing fee. And the same goes for clotting factor. So for those qualified providers that are dispensing clotting factor products, that additional clotting factor dispensing fee will also be added to the base dispensing fee to arrive at the total dispensing fee paid for that prescription. Next slide. This is a very important topic regarding the submission of claims between the medical and pharmacy benefit. So Ohio Medicaid managed care organizations, under their provider agreement with the Department of Medicaid, do maintain responsibility for provider administered pharmaceuticals. Provider-administered pharmaceuticals does include medications that are sent to providers through a white bagging, brown bagging, or similar process, clear bagging. It also includes medications that are given in the home by a home health provider. Importantly to note, it does not include medications given in the home that are self-administered by the patient. Network specialty pharmacies must have the capability to bill via the medical benefit the appropriate MCO for all provider-administered pharmaceuticals, and those are submitted on medical claims. Network pharmacies should also not submit claims to the SPBM for known provider-administered pharmaceuticals. So if a specialty pharmacy provider is aware that the medication will be given by a healthcare professional, we ask that they not submit claims to SPBM for those medications. The SPBM is responsible for the pharmacy benefit only, which are typically self-administered pharmaceuticals. However, there are some exceptions to the provider-administered pharmaceutical consideration here, and those are medications that are provided in a nursing facility or ICF, so the long-term care setting. Another exception is hospice. And then lastly is pharmacist-administered pharmaceuticals that are given in the pharmacy environment. Providers today currently are billing those via an NCPDP pharmacy claim, And we expect that that process can continue in the future for that subset of medications that are given in the pharmacy. And those could be things such as immunizations or long-acting injectable antipsychotics or vitamin B12 injections under state law. Next slide. Some 340B considerations. So 340B covered entities are reimbursed for ingredient cost in accordance with the ORC 5167.123, where it specifies that we will pay no less than the national average drug acquisition cost, or NADAC. If NADAC is not available, we will pay no less than the wholesale acquisition cost, or WAC. And if both pricing metrics are not available, the claim will deny at the point of sale for manual pricing, and the provider will have to call Gainwell to get that claim to pay. Those will be manually priced in accordance with our policies and procedures in the rare event that there would not be a NADAC or WAC pricing available. For 340B contract pharmacies, if those are utilized by the covered entity, they are reimbursed according to the standard reimbursement logic, and that is the lesser of all reimbursement logic, where we'll pull OAAC, NADAC, WAC, and the submitted or usual and customary for ingredient costs. All pharmacy providers are reimbursed the standard dispensing fee, in addition to any specialty or clotting factor dispensing fees. And providers must submit 340B claims level identifiers. This will be detailed in the SPBM provider manual for all claims where 340B stock was used in accordance with NCPDP standards. And so that includes providing a submission clarification code value of 20 and a basis of cost determination value of 0.8 for all of those claims, so that the Department of Medicaid can identify and properly exclude those drugs from our rebate invoicing process. So that is an important consideration, and that claims level identifiers must be used for all 340B claims in accordance with NCPDP standards. Next slide. And at this time, I'll turn it over to Dave Hartzell, Clinical Account Manager from the Gainwell SPBM, to discuss the prior authorization process.
Thank you, Sean. As we get into some of the operational considerations, we wanted to talk about some of the specifics that support that activity. So the first item listed here is around prior authorization forms. And so those are currently available at the website you see listed there. In terms of criteria, those will be available on the SPBM website. And again, the address is listed on the screen here. That website will be going live initially in May. It will have a staggered rollout in terms of content. And so that content will be added to as we go through the summer to the go live timeframe. Prior authorization request will be accepted via any of the methods that you see there. Once a prior authorization has been submitted, Gainwell has 24 hours to evaluate and respond back to the provider and the member. If during that evaluation it's found that further supporting documentation is needed, the prescriber will have up to 72 hours from the initial time that the PA was submitted to Gainwell. After that point, PA determinations will be made. The prescriber will be notified in the same manner that they sent in the request, and the member will always be notified via US mail. And finally, any of the current prior authorizations that are going to be active past the go live date will be transferred to Gainwell so that those will continue to be honored. Next slide. In terms of a representative member journey for that prior authorization experience, we'll start off just by saying that Gainwell's PDL information or Gainwell will provide the PDO information to SureScripts. That service populates most of the e-prescribing platforms so that PAs can be identified during that e-prescribing process. Prescribers can then initiate a PA before the member goes to a pharmacy based on that information. Either way, whether the prescriber takes care of that initially or the member goes to a pharmacy and the pharmacy identifies the need for a prior authorization, sending the information to Gainwell occurs a couple different ways. So if an electronic prior authorization client is sending in their EPAs electronically, those will be converted to faxes and sent into Gainwell. And then once a PA is decisioned, that notification will be again sent back to the member and prescriber. If there's a need to identify a pharmacy, for instance, a new member to the state or someone has recently moved, the member can always, well, anyone can always call the Gainwell Help Desk to help identify a pharmacy. There's also an online directory that'll be available at the website that you see there. And then finally, we have previously talked about specialty pharmacies and the need to have resources to monitor those medications. So again, within the contract, it is required that specialty pharmacies provide a nurse or a pharmacist available by telephone 24 hours a day, 7 days a week. So next slide. At this point, I'll hand it back to Sean.
Okay, thank you, Dave. And at this time, I will turn it over to AJ Summers, Senior Manager from Myers and Stauffer, to discuss the OAAC survey process.
Thank you, Sean. As Sean mentioned, I'm AJ Summers, Senior Manager with Myers and Stauffer, who is ODM's PPAC vendor, the vendor responsible for the OAAC program. So now I'm going to give you a quick overview of the OAAC program. I will transition into an overview of the OAAC survey process, and then I'll follow it up with a review of the timeline of the April 2022 OAAC survey. So OAAC is one of the pricing benchmarks that's going to be included in the pharmacy reimbursement methodology to be implemented on July 1st. OAAC is going to be incorporated with NADAC and WAC for, as Sean had presented earlier, for specialty and non-specialty branded generic, as well as clotting factor. So Myers and Stauffer will maintain OAAC rates primarily through a semi-annual survey process. The surveys are set to take place in April and October of each year. As you may be aware already, the April 2022 survey is in progress and is currently going on. So I'll touch a little bit more on that in a minute. And the April 2022 survey does include all enrolled pharmacy providers. It's important to note that subsequent surveys will include a representative sample of a quarter of the enrolled pharmacy population, as well as all specialty and clotting factor providers. Next slide, please. Continuing with the OAAC program overview, in addition to the semi-annual survey process, OAAC rates will be continually monitored on a weekly basis and adjusted based on market changes, market fluctuations, changes in published pricing, specifically WAC changes, things that directly impact providers' acquisitions costs. And in addition to the weekly adjustments, Myers and Stauffer will also operate a provider help desk that will be staffed between 8 a.m. and 8 p.m. Eastern Time, Monday through Friday, except on holidays. The help desk staff will be available to assist with questions regarding the OAAC survey process, general OAAC program questions and reimbursement questions, and the most important, available for providers to submit OAAC pricing inquiries for review. And again, this will be available, the pricing inquiries will be available on and after July 1st implementation, although the help desk is available to providers today to assist with questions on the survey process and general OAAC program questions. So next slide, please. Transitioning into the OAAC survey process overview, as mentioned, surveys will be semi-annual every April and October. The survey provider population, it will include all enrolled pharmacy providers for this April survey. And then beginning in October and moving forward, it's only going to include a representative sample of the enrolled provider population. However, specialty and clotting factor pharmacies will be included in each survey as this population is smaller, and we need to ensure that we get these acquisition costs. The surveys will be distributed by physical letters and electronically. We mail survey notifications to the provider's mailing addresses that are on record with ODM, as well as the contact email addresses on record with ODM. So it's important to note that providers ensure that their contact information and mailing address information is accurate and up to date with ODM. Then once a provider receives a survey notification, they can provide a response and participate in the survey through 3 primary ways. That is electronically, which is the preferred method. It's the easiest method, and we do encourage providers to submit electronically. They can also submit through physical mail, and they can also fax. So moving into the next slide. The OAC survey process continued. For the April 2022 survey, we do request invoices for the prior month. So for April, it will be invoices during the month of March, and October will be during the month of September. And we ask that providers give us all invoice and purchase records for brand and generic drugs, including specialty, clotting factor, and over-the-counter products. It is important to note that providers should exclude their 340B invoices in this survey. And we have had questions come in already about 340B providers who are 100% 340B. If a provider is 100% 340B, we ask that you send an email or contact Myers and Stauffer. The contact information will be on one of the next slides here, but we have the survey email, ohiosurveys@mslc.com, or you can call us and we will note that you are 100% 340B, and that'll be the way that we note that you've participated. The data elements that we ask you to include are the National Provider Identifier, or your NPI, the National Drug Code, or an NDC crosswalk if NDCs are not available, the purchase price, the quantity purchased, the date of the purchase, and then the purchase record source, which is your wholesaler or manufacturer name. And again, I'll reiterate, electronic submission of the data is preferred. We do have on our website an electronic submission Excel file template for reference if you're curious about what format you can put the information in. Again, it's just a template suggestion, but it is out there. And we also have a copy of the survey notification letter that has gone out on our website as well. The letter and notifications have all the information on how providers can submit, what they need to submit, and when they need to submit. Next slide, please. And now I'm going to walk through the April 2022 OAC survey timeline. As you're aware, the April 2022 survey is in progress. On the 1st, we did send out the initial letters and notifications. I will note, if your pharmacy did not receive, if you are enrolled with ODM and your pharmacy did not receive a letter or notification letter, you can email Myers and Stauffer for a copy of that, or you can obtain it on our website for participation, because the April survey does include all enrolled pharmacy providers. Reminder notifications are being sent out today, the 15th, and then final notifications will be sent out on the 22nd. And the final deadline for providers to submit their records will be April 30th, at which point Myers and Stauffer will begin the OAAC rate calculation process, which will take approximately 4 to 5 weeks. By the end of May, we will then send our proposed rates to ODM for review, to give them several weeks to review, provide approval, ask questions, have any feedback, and make those rates available to providers so they're aware of the rates and what reimbursement will look like. at which point Myers and Stoffer will then adjust the rates based on WAC changes or market changes prior to implementation. We will send those to Gainwell for Gainwell to load into the system for the July 1st, 2022 implementation. Again, providers must submit their records to Myers and Stoffer by April 30th. If you do not submit the requested information by this date, we will mark you down as not participated in the survey, and this information will be reported to ODM. So we encourage you to get your information submitted or reach out to us ahead of time to notify that you're working on the submission. Next slide. This slide just gives you contact information for Myers and Stoffer to contact our help desk for any questions on the survey process or the program or OAAC rates in general. We have the phone, the email address, and the URL to our website. And with that, I will kick it back over to Sean for next steps.
Yeah, thank you, AJ. At this time, we'll talk about some next steps. Next slide, please. So some upcoming topics within the SPBM PPAC stakeholder meetings. We are planning to hold an SPBM pricing discussion. This was originally scheduled for mid to late April, but we are going to be required to move that back to allow us some more time to assess the OAAC survey participation and the impact that the participation rate will have on the fiscal modeling. So once we're able to confirm participation rates and the quality of data received, at that time we'll be prepared to release the dispensing fee rates and have that conversation with the provider community. It's also important to note that OAAC rates currently are not planned to be available until June. But these rates will be transparent, will be posted online. And so that is another consideration around the ingredient cost structure. Next slide. Regarding questions, ODM will be posting an FAQ document that addresses the questions received to date. And this will be located on the ODM SPBM Managed Care website, which is provided at the link on the slide. It's important to note that this FAQ document will be updated periodically to provide answers to questions received. So we very much intend that this will be a living document. So please be sure to check back to that FAQ document frequently as we will be adding content to that. Otherwise, we ask that you please direct questions to ODM at the email address indicated below, which is Medicaid SPBM, all one word, at medicaid.ohio.gov. Next slide. This slide we just provide as reference for those pharmacy providers, specialty pharmacy providers particularly, that may need to reach out to each of the managed care organizations for contracting purposes, particularly around those drugs that will be covered under the medical benefit. So we just provide this as a source of reference for each of the managed care plans. At this time, I'd like to thank everyone for their participation and attendance at this stakeholder meeting. We look forward to continued engagement with the stakeholder community in the coming weeks and months leading to implementation of the SPBM program. Certainly appreciate your attendance and please have a great weekend. Thank you very much.